In this segment, I'm going to talk about fungal infections. All right, so first off, we'll start with the nurse monitoring pearls here. With antifungal medications, probably the most common class is azole antifungals. A few important points, really critical. Drug interactions, CYP P450, CYP3A4, and other CYP enzymes as well. Really important to pay attention to drug interactions when you get a prescription for an azole antifungal. QTC prolongation I'd put in that bucket as well, drug interaction. And then rarely can cause some hepatic issues, so we may monitor LFTs and things of that nature. Amphotericin B, tons of clinical practice pearls with that medication. Renal function needs to be monitored. Electrolytes need to be monitored. And clinically monitoring those patients for infusion-type reactions. It's an IV medication. It can cause an infusion-type reaction that causes fever and chills and low blood pressure and phlebitis as well. Super important to pay attention to that. Obviously, when we're giving any type of antifungal, antiviral, antibiotic-type medication, we got to pay attention to therapeutic response. Is that infection, what we're trying to treat, getting better? Okay? If it's not, definitely need to say something for sure to the provider. Adverse effect profile for these medications in general, rash, GI upset, headache. Voriconazole is associated with kind of a visual type disturbance. And then obviously looking at the list above of the azole and amphotericin B. I'll get into that in greater detail here coming up. And then last but not least, we're treating an infection. We got to make sure patients are taking the medication, correct dose, duration, and of course making sure that medication is being administered appropriately in those patients where we need to do that. All right, getting into the drugs more specifically, we got triazoles, often called the azole antibiotic. The differing names and classifications, they kind of depend upon their chemical structure, so I wouldn't stress too much about that. But if you see the ending azole, like fluconazole, voriconazole, that's indicative that you're dealing with an antifungal agent. Okay. Mechanistically, what do these drugs do? Well, they inhibit fungal cytochrome P450 dependent enzyme lanosterol, which converts lanosterol to ergosterol, which is important in fungal cell wall synthesis. So that's basically what the mechanism comes down to. GI adverse effects are going to be most common, some nausea, stomach upset, things like that. Those LFTs may need to be monitored. Liver function, liver failure is a possibility. Notorious cause of those CYP interactions, 3A4 particularly. Some azole antifungals do inhibit other enzymes as well. So again, these are meds that I would encourage you to look up and double check if you see a prescription order for these, particularly in our polypharmacy patients where that there's likely going to be an interaction somewhere. So pay attention to that. Notify the clinician accordingly if something comes up on a drug interaction screen. Can potentially cause QTC prolongation as well. So if you know a patient is at risk for that, that's in their record, it's in their medical history, they're taking antiarrhythmics, they're taking antipsychotics or other meds that may increase that risk, definitely something that needs to be pointed out, and clinician may go on to order an EKG, for example, to make sure that QT interval on EKG is not too prolonged to take this medication. Next medication I want to talk about is amphotericin B. This binds ergosterol, which alters the fungal cell membrane and ultimately leads to fungal death or incapacitation. There are two different kind of formulations of this. It is an IV medication. There's conventional and lipid-based formulation. Lipid-based formulation is generally more expensive, but it does potentially reduce the risk, of nephrotoxicity as well as infusion reactions. So I would say those are the two biggest things I would commit to memory with amphotericin. we got to pay attention to kidney function, and we got to pay attention to the risk for infusion reactions. Okay. Those formulations are not interchangeable. So if you see an order for amphotericin B, and you're not seeing, maybe the MAR jive with the order or jive with what the pharmacy sent, definitely a great one to ask and double check, because there definitely can be errors with those different formulations. That definitely has happened. Now, the infusion reaction, we may use what's called pretreatment, so basically giving meds to reduce the significance of a potential infusion reaction. Diphenhydramine can be used for its antihistamine type effect, maybe reduce itching and provide a little bit more comfort there. And then acetaminophen or an NSAID, this can help with reducing the risk for fever and pain and those type of things. In some patients, we may consider corticosteroids as well. Again, may depend upon past history, the severity of any type of reactions they've had in the past, or anything like that. That infusion reaction can cause basically flu-like symptoms. So chills, headache, pain, low blood pressure. The risk of some of these reactions generally is higher earlier. So more common with the first dose, second dose, those first couple doses is where you're probably most likely to see that infusion reaction, rather than, 5 days later, a week later. Odds are likely they're probably not going to have that big of a reaction, because their body's obviously used to it, and obviously probably not reacting to it like some other patients can. So again, still something you're probably going to pay attention to, 3, 5, 7 days down the road. But as we get further out, it's generally less likely that you're going to have that specific reaction. Electrolytes, important with amphotericin B, can cause hypokalemia as well as low magnesium. Then monitoring that kidney function. And then there is a boxed warning because of all the risks associated with this medication for the conventional amphotericin B. It's to be reserved for use against severe and life-threatening infections. So you can probably gather, if you see an order for amphotericin B, it's a pretty severe type infection because of all the risks associated with this medication. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology Crossword Puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse. The other class of medications I wanted to mention are the echinocandin medications, caspofungin, micafungin, so that fungin ending. Hopefully you're able to pick up on that. These inhibit 1,3-beta-D-glucan synthase, and this is, again, kind of similar. It's another key enzyme involved in that pathway of forming the fungal cell wall. These are IV only, so again, you're probably dealing with a sicker patient if they're hospitalized in that setting. Typically better tolerated than systemic amphotericin B or azoles. Lower risk of infusion reaction, less impact on liver function as well. The coverage and the clinical evidence may be a little bit less with some of these agents, so that can sway selection of these drugs as well. All right, a few common infections I wanted to just mention at least that are fungal infections. So tinea pedis is also known as athlete's foot. Very common. It's picked up typically in those warm, moist environments. I always think of shared showers or community showers in locker rooms, things like that. Again, we've got a warm, moist environment. We've got, multiple people potentially sharing that area. It can easily obviously be spread by touching, contact, water, and shared water, that type of thing, and be transmitted from one person to the other. Treatment, we're going to typically do topical treatment. Fungal infections in general do take a while to treat, and athlete's foot is certainly no exception there. So that's an important education piece. I think you guys absolutely should remember and tell patients about. I have had patients in practice where they come in, pretty sure they've read online that they've got athlete's foot, itching between the toes and burning and, skin kind of sloughing off a little bit. In that situation, I've had many patients try something for 3 days, 5 days, and they expect it to be gone. And that's just typically not the case with athlete's foot. It definitely takes some time, takes some patience, and takes some treatment there. We typically do not use oral medications for athlete's foot. We're going to stick to topical. If we do, because of a severe case or a non-responsive case to topical agents, keep in mind what drug you're using and some of the potential downsides to that. Tinea curis. So this is commonly called jock itch. Similar type of thing. Warm, moist environments. Under and around the scrotum, that type of thing for males there. Definitely common infection, more so in warmer climates, summer, that type of thing. Topical agents here are what's going to primarily be used. A drug like clotrimazole or terbinafine is a good example of that. And ringworm, same type of family, same type of agents there. Ringworm, just kind of a skin type infection, fungal infection, can occur, virtually anywhere on the body, is generally passed by contact and those type of things. Again, topical agents utilized primarily there. Maybe in severe cases or non-responsive cases, we may consider oral antifungal medications too. Thrush, this is Candida albicans. This is a white, gunk that can cause some pain, inflammation, and difficulty swallowing in the throat and mouth area. Pay attention to patients who are immunosuppressed, so those on chemotherapy, those on corticosteroids, and I would include inhaled corticosteroids here. This is the reason, one of the primary reasons why we rinse after using an inhaled corticosteroid for, let's say, management of asthma. Okay, so after the inhaler use, we rinse and with water, and the primary reason is to try to reduce this risk of thrush. Treatment, clotrimazole troche, nystatin topical. There's a few different options there, and we can use systemic therapy as well if cases are severe. Yeast infection, another good one to remember. Candida albicans can cause some itching, burning, cottage cheese type discharge from the vaginal area. May be worsened or caused potentially by changes in normal flora. So many times you'll see patients get antibiotics for an infection, and what that does is it kills the normal flora, and that allows for something like a yeast infection to grow. Okay, so that's often what happens here. So if you notice that, that's a good thing to educate patients about, and it's also a great reason why we try to limit antibiotic use as well whenever possible. So paying attention to that's important. Topically, we can typically treat this. In rare cases, may need to do some systemic therapy too. Last one I'll mention here is PCP pneumonia. So that's pneumocystis carinii pneumonia. It is actually treated with Bactrim, which is classically referred to as an antibiotic. But this is kind of one of the rare infections that you may see used here. It's often shows up in immunosuppressed patients, and in some patients with chronic immunosuppression, like HIV/AIDS patients, we may utilize this on a chronic basis. Okay, so to reduce the risk of that showing up there. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course.